Welcome everybody to today's Occuplasty session. As you have seen that today's session is called Upskilling, and upskilling is a very trendy word nowadays. Mostly the techies use it. But let's remember that as doctors, this is something that we constantly do. And for oculoplasty surgeons, it's been a very exciting time that we need to keep up with what is new coming in. And to begin with, one of our keynote speakers, Dr. Kasturi Bhattacharjee, is going to help us do just that, talking about new technologies in oculoplasty. Dr. Kasturi needs really no introduction. She is at Sri Shankaradeva Netralaya, Guwahati, and she's a very accomplished surgeon, an excellent speaker, and has a deep knowledge of a wide range of topics. Welcome, Dr. Kasturi.
Thank you, Dr. Rashmi, for the kind words. Am I audible, Rashmi?
Yes, quite clear. Thank you.
Okay, let me increase the sound. Okay, so my topic is the new technology in occuplasty. So let me start by mentioning that we all know the human self an innate inquisitiveness towards exploring the unseen. And in occuplasty, the most important innovations, basically the navigation, the 3D printing, the patient-specific implant, the robotic surgery, and of course the AR, the AI, and the VR. So when I talk about navigation, I have been using it for the last 5 years for multiple indication. I use the StealthStation, dodera, and the system. Navigation is basically something like a GPS, which gives you a roadmap. Exactly, it tells you where to reach and when to reach. And here the data is preloaded into the computer and you get the real-time updates. The data are in the form of the CT, MRI, MRA, and the real-time updates are basically the intraoperative localization and the endpoint of the surgery. It has this fantastic software which equips us with tools for the differential color coding, the precise marking, and the mapping of the site of the pathology. So you can incorporate the CT, the MRA, the MRI, and then it usually helps you guide during the surgery. And most important application is during the case of fracture, especially in unilateral cases, where what we do a segmentation, we do a mirroring. When we merge the mirrored orientation onto the original, identify the defect, quantify the displacement, and design the patient-specific implant. So I have been using it extensively for a very complex surgery where both the horizontal and the vertical buttresses are being involved, which involves the rim, which involves the wall of the fracture. And this, you get real good reconstruction, especially in challenging situation like this, which is NOS fracture, where you can see the fractures on the one side. So I have mirrored the normal over the abnormal, and you can measure the exact amount of volume that you'd like to place in this patient. And as you go ahead with the surgery, for me, the fracture surgery, always a transconjunctival approach. Even when I do the repair of the zygoma, I might give a hemicranial approach, but definitely the orbite fracture is a transconjunctival. And here you can see this horizontal buttresses are being involved. So first you need to repair the buttresses. And once you're done with the buttresses, then you try to release the tissue. The most important thing that you need to give the volume. The MTB, which you can see that we are giving here, and then it corrects the volume deficit, which we have already measured how much amount of volume needs to be given. And this is the endpoint of the surgery, which tells you, yes, that you have placed the implant in the correct localization. And you get comparatively good placement of the implant and the good cosmetic results, as you can see here. Most important, where to place and the endpoint of the surgery. These are few of the patients were all done under navigation, real complex cases, and where you can see the medial and the inferior implant placed very effectively. Challenging situation like this, where you have great amount of inophthalmos or more than 4 millimeter with dystopia of the globe, dystopia of the medial canthus, and most important, total destruction of the canalicular system, where you need to do a conjunctival DCR along with a fracture repair. So once you do the mirroring here, here I have done done a conjunctival DCR along with the repair of the fracture. And you can see here the whole skull I have mirrored, the normal over the abnormal. And then once you start with the surgery, you can see the first, definitely, since I need to do a conjunctival DCR, I'm doing a DCT. And this is being followed by the creation of the mucosal flap. This mucosal flap, which you just roll it over a tissue, over a tube, which can be either the silicone tubing or the phaco or even the mini monoca. And once you wrap it, and then one end you suture it to the DCR end, and the other end nasal mucosal end, and other to the conjunctival end, and you make a new conduit, you make a new track, and this is being followed by your repair of the fracture and also the repair of the canthal dystopia. And this is what you see, that like this is really a Tumors, which you can see the before the operation. And then the most important thing, that the horizontal and the vertical buttresses are being managed so well. And here you can see that the square shape, the rectangular shape, the expanded bony socket has been converted so well with the placement of the implant and appropriate correction of the volume. You can see the oval shape has come back. And this is a 3-month post-operative. You can see here with the movement in all the direction and comparatively adequate correction. I'm sure it will improve more because it is only a 3 months post-operative period. Navigation, I have used it extensively for any trauma of the optic nerve, because we know the optic canal, which is deep inside the orbit, approximately 42 to 46 millimeter orbit, and any trivial injury in any part of the face can lead to traumatic optic neuropathy, which can be in the form of an indirect traumatic optic neuropathy, or direct in the form of a fracture, or in the form of the hematoma. So what the navigation does here, as mentioned earlier, it serves as a GPS in which we set the target to reach the destination. We load the data into CD, then which goes into the console. And then you need to read the CD in both the coronal, the horizontal, and the axial. You need to set the point of entry and the targeted area that you need to reach. Once this is being done, then you need to do a registration. So this, once you draw the cylinder, you go ahead with the registration, and then you create this magnetic field here, and then this stylet will guide you in every step of the surgery. Like even I feel that when you do a case of traumatic optic neuropathy, without this navigation, it's very difficult to reach deep inside the orbit, where at the initial end, you know that you have reached the anterior ethmoid, you cauterize it, go further posterior till you reach the posterior ethmoid. Now you put the navigation stylet here, and it tells you that yes, you are in the posterior ethmoid, as you can see here. So it has guided you that you have not yet reached the optic canal, so it will guide you in the direction in the cylinder that you have drawn, and then till you see the annulus of the zinc, the Y-shaped annulus of the zinc, as you can see here. So then you try to decompress here. Initially, I used punch, then you can use a sharp neurosurgical instrument, and then you decompress the canal. These are the optic nerve sheath hematoma, so I make some incision with the MVR in order to release the blood. So in such situation, like it really helps, and without this, it is not possible to reach so deep into the orbit. So this is very interesting. I like to show you, like if you look here, when I was doing the surgery, every time I put the stylet, it goes into the sphenoid sinus. So I have realized that I am not in the correct direction. So then I revised the line of my cylinder. And then now once I have further decompressed, and now when at the end of the surgery, you can see my stylet shows yes, this is the optic canal right from the orbital to the cranial, and you can see so well the whole of the canal has been decompressed in all the coronal, axial, and the sagittal. I use extensively for very complex cases, and especially even being an ophthalmologist alone, you can take up such challenging situation when you have a metallic foreign body embedded right in the frontal bone and towards more in the cranial cavity. What you need to do, you need to draw the cylinder, just follow the cylinder that you have drawn, and you can very well remove the foreign body like this. And this is another interesting way. You can see a foreign body in the lateral wall, that is in the greater wing of the sphenoid. And as I do the surgery, I make an incision over the periosteum and then release the tissue. And then I was trying to find this foreign body, I was not getting it. So as because I have already used the navigation, and now it gives me the direction, in which direction I need to go. And you see exactly this is where the foreign body is sitting. And then as because it's embedded, I have to drill the tissue around it. So the tissue has been drilled out, and this had led a very easy removal of the foreign body, as you can see here. And this is being followed by closure in layers. So And also the navigation helps in more complex surgery. I think I'll just skip this slide. Like it really helps you to do very challenging situation, especially for the tumors situation where it goes deep within the orbit. As you can see here, there are lots of indication of the navigation. So besides the navigation, there are other technological advances which I would like to mention, the 3D printing. This has really revolutionized today the fracture management, especially when you have situation like this, when you have a bilateral situation where you have the image in the 2D image, then this gets converted into the 3D images, and ultimately you have the 3D modeling and then export in the STF format. And this is what I would like to show you some very two interesting cases. Like, see, it has got a bilateral fracture. So in this situation, you cannot do a mirroring. So what we have done a 3D printing, and before the operation, you can plan, you can see the amount of inoculums in this patient, and this is at the end of the surgery. This is a very early cases, approximately 3 to 4 months, and you can see a good correction of the inoculums. And more interestingly, in this patient where there's total dystopia of the globe, and when you see her this amount of the inoculums, so I had done, and you can see the bilateral fracture involving the zygoma. So it's a very interesting case that I had done recently where you can see the whole of the zygoma has been totally depressed with a depressed fracture. So what I had done a hemicranial coronal approach, and once then you need to expose the zygoma. So once you expose the zygoma, you can see this is the depressed zygoma. So what I believe that in case you have a depressed zygoma, if you do not manage this, then you will not be having an adequate correction or shape of the orbit post-operatively. And then the depressed part are nicely, I mean, plating has been done in all the three parts, then you close the incision, and after that you need to do the orbital component. As I have already mentioned, orbital is always transconjunctival, but here, as because she has a scar, I have gone through the same incision. Then once the horizontal buttress is being managed, the next the implant is being placed, and then it is being sutured in layers. And this is a very early, I think I had done it only last week, and this is the amount of the inoculums that she had before the surgery. And this is a picture that she had sent me today. You can see multiple Z-plasty has been done in order to correct the soft tissue. Other uses of this 3D reconstruction, especially when you have a unilateral inoculums like this with so much of contracted socket. And this is a very challenging case who had visited, undergone operation multiple times. And when you have a grade 5 contracted socket like this, so this will really help you develop some innovative technique. Like now I have done a 3D printing. I know how much amount of the contracture is there. So what I have done, I have cut this maxilla in such a fashion that there's a posterior bony contact. So this is the maxilla that has been cut, and this is the maxilla that has been done a forward replacement. So anterior replacement projection has been done, and then there should be a bony contact at the end, otherwise this bone will not take place. And then as usual, what we do for accentuated socket, we go for temporalis muscle transfer, and then I usually put an amniotic membrane at the end so that it gives a very good healing of the socket, and at least this patient could place a implant following this procedure. So these are some of the advances, and one very important advances in occuplasty is the PSI, the patient-specific implant, which basically has a three-part to it: the designing, the fabrication, and the clinical application. The surgeon has a very important role in designing, in specifying the cross-section, in specifying the key points, but this is a very costly procedure still for us. Then we send it for fabrication, and then once it goes in process quality control and the final quality control, you get it with and which needs to be sterilized, and then you use it during the surgery. So the workflow is basically you do the CT, MRI, and you have the DICOM images, and segmentation is being done, and then the still export, the slicing, and then you get the 3D printing, which can be used for the patient. Other advances being the artificial intelligence, and there are lots of studies coming out, especially for the screening of many of the occuplasty disease, like the thyroid eye disease. And then the robotic surgery are also coming. There are literature where people are using robotic surgery to reach the hard to reach area, especially the orbital apex. And the most important, which really attracted me, is the application of the AR, that is the augmented reality. Advantage of this augmented reality is that you see live images, and the most important that has an advantage over the navigation, because navigation you need to look to the system. Here you do not need to look to the system, and the microscope system has already come available now. where as you go deep, you can have the images, all the live images of all the important structure, whether it is a nerve, blood vessel, veins, and then it gives a very safe surgery. So this is a great boon for especially the orbital or the apex surgery, and I'm sure it is a real great boon for the oculoplastic surgery. So I end this inviting all of you to the first webinar, OPI webinar, which is on both the balancing the lateral and the medial canthus. Thank you very much for your patient hearing.
Thank you, Dr. Kasturi. That was a set of very exciting advances, and we look forward to hearing more from you in the future. We will take all the questions and discussions at the end. We will now move on to the talk with Dr. Santosh Honavar, whose name once again needs no introduction. This is the second keynote lecture. He will be talking about the advances in the orbital tumors. Shambhavi, will you play the video, please?
Yes, doctor.
Dr. Honavar will join us soon.
Okay, doctor. I will play.
I thank Karnataka Ophthalmological Society, specifically Dr. Roshni Gupta and Ellen Kumaran, for the opportunity to speak to you at the KOS conference in the Occuplasty session. I was asked to speak on the current concepts in the management of orbital tumors. 50% of orbital tumors are malignant and are potentially life-threatening. So there is always the role for life salvage, eye salvage, and optimal vision salvage and cosmesis. And you have to weigh the balance of each in a given patient. Simple oncological principles for orbital tumors are that when there is a well-circumscribed tumor, which is unlikely to have functional deficit on excision, you would want complete excision of such tumors. But if the patient has a tumor which is infiltrative, excising which is likely to cause a functional deficit, then you would go in favor of an incisional biopsy or safe debulking with intraoperative diagnosis. There is always a role for histopathology guided adjuvant treatment. And of course, one of the current concepts in the management is multimodal treatment. So I'll be talking about non-surgical approaches to orbital tumors, understanding of the role of incisional biopsy, minimal access surgery, and multimodal treatment. Starting with the non-surgical approaches. This patient doesn't even seem to have proptosis, but he's an airline pilot who was disqualified from flying based on his visual field defect. And when imaging was performed, he was found to have a cavernous hemangioma sitting right at the orbital apex, impinging on the optic nerve and the superior orbital fissure. This is how his visual field is. Cavernous hemangioma is a surgeon's delight, and if you were to try to operate on this patient, of course, you'll be meddling at the superior orbital fissure and orbital apex. Thus, possibly you could cause ocular motility disturbance and diplopia, or his vision may even drop. So short of surgical excision, in this patient, we planned stereotactic radiation, preserving the optic nerve. And consequently, his tumor reduced in size to about 20 to 30% of its initial volume, and his visual field defect also returned to normal. There are many similar cases in the literature. This one is striking as well, where gamma knife radiation was given at a much lower 2000 centigrade, and his near total loss of visual field defect returned to normal, and the small tumor that he had at the orbital apex became much smaller. So the current concept is that if there's a tumor in a crucial location, visually crucial area or a functionally crucial area, try not to excise it and explore for alternative therapeutic modalities. Coming on to injection, we're all familiar with the use of bleomycin for orbital lymphangioma. We can use picibanil as well, which is a much better drug, I feel, but it's difficult in terms of importing it, but it is a much better drug with very less inflammation potential. This was a young lady who had axial proptosis of the right eye and recurrent perilesional hemorrhages and subconjunctival hemorrhages. She wanted cosmesis, but a tumor is all around her optic nerve and the extraocular muscles, thus precluding debulking. So when we injected picibanil in this patient, tumor nicely cleared out and she got the cosmesis that she always wanted. That's how she looks after 2 injections of intralesional picibanil. If a patient has macrocysts like this, where the tumor is filled with blood, we aspirate the blood and then inject bleomycin or picibanil into the macrocyst. In a patient who has a microcyst, the response is slightly less as compared to the macrocyst. This is a patient where there was a large chocolate cyst and it actually simulated rhabdomyosarcoma, warranting an incisional biopsy, confirmation of diagnosis, and then injection of bleomycin here, and the patient did well. One more patient where anteriorly located lymphangioma was debulked and the posterior component was injected with bleomycin with good results. Again, a similar patient, anterior lymphangioma injected with bleomycin. Apart from bleomycin injection for lymphangioma, we have one more indication for intraorbital injection, that is eosinophilic granuloma. This child has a lesion at the superior orbit, destroying the roof of the orbit and infiltration of dura. This looks like eosinophilic granuloma, but then if you were to curate it as is the classical treatment, then you'll be disturbing the dura here and the child would need a major surgical intervention. Short of that, we would do an incisional biopsy right from the center of the lesion in a safe zone, get an intraoperative diagnosis. That's the area where biopsy could be performed by a sub-row incision, get an intraoperative diagnosis. And once we confirm the diagnosis, that is, it is indeed eosinophilic granuloma, all that you need to do is inject triamcinolone into the lesion. And over a period of time, you can see complete remodeling of the bone without any need for major surgery. That's how we currently treat eosinophilic granuloma. One more similar child where there is actually a breach in the roof and you can see that the tumor is jutting into the dura. Again, this biopsy confirmed the diagnosis that it is eosinophilic granuloma. After injections, a couple of months later, you can see nice remodeling of the bone has already started and this erosion will ultimately remodel itself without any need for major surgical intervention. Now going on to orbital biopsy. How deep is deep enough? We understand that about 8 to 20% of orbital biopsies result in non-specific or misleading diagnosis. It could be because of unrepresentative sample, non-uniform pathology on part of the tumor itself, or we would have biopsied from the area where there is secondary tissue reaction, not the tumor itself. Example is this child with rhabdomyosarcoma. I always do biopsy from the superficial zone, mid zone, and deep zone past the epicenter. And we send all these samples to the pathologist. So we have an opportunity to analyze how did the superficial biopsy look like, how did the mid-zonal biopsy look like, and how did the deep biopsy look like. In this patient, superficial biopsy consisted of only inflammation and fibrosis. Very clear. Suppose we were to only do a superficial biopsy in this patient. From this zone, we would have got inflammation as the diagnosis and possibly treat the patient with steroids with disastrous results. Only in deep biopsy did this patient show rhabdomyosarcoma. Rhabdomyosarcoma being a round cell tumor, it is possible that the tumor undergoes necrosis and even deep biopsy may have necrotic elements, thus making the diagnosis difficult. So we have to have multi-zonal biopsy to confirm the diagnosis in any given patient. This is a patient with bilateral orbital tumor, more in the left eye than in the right eye. Sort of a midline tumor extending into paranasal sinuses as well. Here the superficial biopsy showed inflammation and fibrosis, and only deep biopsy showed granulomatous inflammation with multinucleate giant cells, and that is not enough. So in such patients, we have to also ask for special stains. In this patient, GMS stain showed fungal elements, confirming that it was fungal granuloma. So we have to look for, based on the suspicion, we can ask for specific microbiology tests, special stains, and PCR. So principles in orbital biopsy are that we have to do a layered biopsy. We have to do superficial, intermediate, and deep biopsy well past the epicenter of the lesion. And the depth is always estimated based on radiology. We can actually do frozen section or imprint or squash techniques to know the intraoperative diagnosis, to understand whether we need to debulk the tumor further or take risk and completely remove the tumor. That is necessary in patients where the tumor may be of the kind that where chemotherapy and radiation may not work. So intraoperative diagnosis actually helps you manage the patient. If you were to have any confusion at all about the depth of the lesion, you can always use navigational techniques to know exactly where you are within the lesion and go and biopsy from the part that you actually want to biopsy from. Going on to minimal access surgery. We all use minimal access surgery currently. Transconjunctival incisions have become very popular. You can use these for medial orbital lesions, inferior orbital lesions, and even lateral orbital lesions. Almost about 270 degrees of the orbit can be covered with hidden transconjunctival incisions, both for intraconal as well as extraconal. This is a child with Ptosis at birth. It gradually started increasing at about 6 weeks of age. We did a scan and we found a tooth inside it, confirming that it was actually a teratoma. In this patient, the tumor was on both the sides of the optic nerve, medial as well as lateral. So here, transconjunctival incision was performed. That is the lateral cystic component, and that is the optic nerve, and that is the solid medial component. We could expose all the structures and safely remove it without any complications by using this panoramic approach. Although the child has residual is a squint that needs to be corrected, but there is no stigma of surgery in this child, and there is no complication of surgery. This is an elderly individual with a orbital cavernous hemangioma impinging on the optic nerve intraconal lesion. Here we again use transconjunctival orbitotomy. Steps are very simple. You begin with a small lateral canthotomy and an inferior cantholysis. Then you make an incision right close to the inferior orbital margin in the fornix. Retract the tissues, use a spatula to palpate the fornix, palpate the inferior orbital margin, and make an incision in the periosteum very close to the inferior orbital margin. Dissection of the periosteum till you reach the apex of the inferior orbital fissure, or you visualize the infraorbital nerve, and that is followed by incision in the periorbita in the quadrant where the tumor is located. Separation of fat using retractors, very gently dissect the tumor under visualization using a microscope till you dissect about 2/3 of the tumor. Then apply cryoproof for anteroposterior traction and gently wriggle the tumor out, supporting it posteriorly. And as the tumor comes out, you have to visualize the posterior vascular pedicle and cauterize it if required to avoid secondary bleeding. All that we need to close here is the inferior fornix and reform the lateral canthal angle. That's how we close the inferior fornix with buried knots, and the patients remain comfortable following surgery. The same patient after about 3 weeks without any stigma of orbitotomy. Again, a cavernous hemangioma removed by a similar technique. Irrespective of the size of the tumor, this technique is very helpful. Now going on to histopathology guided adjuvant therapy. This is a patient with solitary fibrous tumor, but then there is cellular atypia and the tumor is just gotten into the infraorbital nerve. In such patients, we have to give external beam radiation based on histopathology. If there is cellular atypia, if there are mitotic figures, and if it's a infiltrative tumor, then external beam radiation actually helps reduce the chance of local tumor recurrence. Again, a SFT in a young individual, following removal, we did external beam radiation as adjuvant therapy, and the patient is tumor-free. In patients with lymphoma, if there is, depending on the stage of the lymphoma, we might want to give systemic chemotherapy. And in such patients, we can do a gentle form of chemotherapy using bendamustine and rituximab. Patients remain very comfortable with this sort of therapy. Coming on to target therapy in patients who have lymphoma of the orbit, the anterior component being very predominant, which can be excised. But for the equatorial component, excision becomes quite difficult. Only other option being radiation. Short of that, we can use perilesional rituximab, as was used in this patient. 3 weekly injections, 6 injections, and the residual tumor completely resolved. For melanoma, we have the mutational spectrum completely worked out, but melanomas are rare in the orbit. Despite that, we would like to know that there are target therapy for orbital melanoma, target therapy for conjunctival melanoma, which also work in resolution of the primary tumor. This patient was given nivolumab for regional lymph node metastasis, and the conjunctival component also started regressing. We can use erlotinib, which is an epidermal growth factor receptor inhibitor for inoperable squamous cell carcinoma, and for basal cell carcinoma with orbital extension, which is inoperable or patients are too old to get surgery, then we can use vismodegib or Erivedge to stabilize the tumor. We should realize that micrometastasis can be taken care of by only systemic therapy. So adjuvant chemotherapy and biologicals do have a role. Coming on to multimodal treatment, orbital exentration is maybe locally curative, but is a high rate of systemic metastasis. So we use orbital For orbital retinoblastoma, we use multimodal therapy with good success. For rhabdomyosarcoma, etc., where there is tumor around the inferior rectus muscle, we can spare the muscle, leave a wedge of the tumor behind, as has been done here, and the residual tumor can be treated with chemotherapy and radiation. Exentration, if required, can be made safe by using neoadjuvant chemotherapy. In adenoid cystic carcinoma, it is a specific role where after beginning with neoadjuvant chemotherapy, tumor has visibly shrunken, at which point in time you operate and then deliver extended field external beam radiation and finally complete with adjuvant therapy. You don't have to remove the involved bone in adenoid cystic carcinoma anymore. It completely remodeled. So with minimal intervention, you can have good results. This is a child again with destroyed bone with adenoid cystic carcinoma. You can see complete remodeling of the bone with conservative treatment. This is a patient with recurrent adenoid cystic carcinoma with prior excision and prior external beam radiation, but then the patient has recurred. So we use a special form of radiation here where we implant silicone tubes and do what is called afterloaded brachytherapy using iridium-192. In adenoid cystic carcinoma, multimodal treatment has excellent success with reduced risk of local tumor recurrence, improved eye salvage, improved need for orbital exentration, and also very minimal, that's only 5% risk of systemic metastasis, with excellent survival in all forms of tumors. So in conclusion, I would say that there are a lot of new changes in the management of orbital tumors. We have targeted therapy, new forms of chemotherapy, innovative use of radiation, and minimal access surgery predominating in the management with much better outcomes. Thank you so much for the opportunity.
That was a wonderful talk. Since Dr. Santosh has not been able to join us yet, we'll leave his questions for later. Does anybody have questions for Dr. Kasturi? She talked about so many new conditions, so many new applications. It was opening up a very exciting vista. Dr. Kasturi, I have a question. When you're talking about patient-specific implants, so nowadays, are you just modifying the available implants, or are you placing orders for the implants to be manufactured, or how is it that you're going about it?
Yeah, there are two ways. Like if you have a navigation system and you can measure the amount of the volume deficit, I mold the implant and that becomes cheaper for the patient. But for the PSI, which you need to fabricate, it was a very costly. Stryker does it, but it's extremely, extremely costly. I just have experience of only one patient, but rest all my patient I molded. And sometimes even I layered implant I give one about the other. So I think this really has given a comparatively good result in Indian scenario. But definitely you can measure the medial, inferior, lateral wall, and according, there are many times even either plain titanium, I just mold it in different direction, and that also gives a cosmetically good correction.
When you're talking about layering an implant, are you layering the porous polyethylene implants or even the titanium implants?
Titanium already comes, the MTM, that is the Med4, titanium Med4, those
Yes.
are thick implants. But and see, like if you have a deficit, like it comes approximately thickness of 1.5 millimeter, and there is MTM which comes a bigger, maximum 2. So 4 millimeter, what I see when I get a deficit of approximately 6 millimeter in my navigation, that means I need to make a correction of 2 millimeter. So that is what in my system, that is for every 6 millimeter that I measure, I need to give 2 millimeter. Every 12 millimeter I measure, I need to give 4 millimeter. So if you, with the same implant, if you can mold it, so 2 millimeter you're giving from the floor and 2 millimeter medial wall. So this is giving the 4 millimeter correction, which is approximately 12 millimeter of the difference that you see.
Okay, that's very interesting. Does this calculation hold true for all navigation systems, or it is something you have found by experience?
Only by experience. I have used only the SteelStation 8. I don't know about the other system, but I have done it it needs to be validated. Now I'm writing a paper on it, and once it is validated, like we can have more discussion on it. I don't know about the other system because there are people using Stryker and Brain Labs. all the other system also.
Well, thank you, Dr. Kasturi. You've been a fantastic speaker, and thank you again for being with us
Thank you so
today.
much, Lakshmi. A real pleasure and honor.
Shambhavi, now
Yes,
we
ma'am.
will probably move forward. Thank you.
Okay. Next is Dr. Rashmi.
Today we will be talking about vascular malformations of the orbit, and I thank Karnataka Ophthalmic Society for giving me this opportunity to be with you here today. Vascular anomalies of the orbit is a complex entity, and the Orbit Society classification divided it on basis of hemodynamics into no-flow lesions, venous flow lesions, and arterial flow lesions. It may also be classified by location, such as superficial, deep, and combined. The current modified ISS VA classification combines classification by tissue of origin along with the flow characteristics such as high flow lesions and low flow lesions. They may be malformations or proliferative lesions. The vasoproliferative lesions include the commonly seen infantile hemangioma, previously called capillary hemangioma, which first is seen at around 3 months of age and reaches its maximum size by about 5 or 6 months of age. It may cause amblyopia because of ptosis or astigmatism, and it is treated by oral propranolol starting at 0.5 milligram per kg per day, increased to 2 milligram per kg per day by observing for adverse events. It needs prolonged comprehensive treatment. It may also be treated by use of intralesional steroids. We inject beclomethasone 6 milligram per ml with triamcinolone, and we inject in 0.1 ml aliquots with slow injection without excess pressure. We monitor the central retinal artery. The downside of it is it may cause hypopigmentation and other steroid-induced side effects. Congenital hemangioma is to be differentiated from infantile hemangioma. It does not improve with propranolol or with steroid injection and will need surgery. Among the vasoproliferative lesions, the benign acquired lesion includes the pyogenic granuloma, which is usually excised. It may also respond to topical timolol maleate. Among the malignant lesions is the angiosarcoma, which needs extensive surgery and radiation. When we come to the vascular malformations, the malformation of lymphatic origin may be macrocystic or microcystic. It previously was known as lymphangioma and may present with sudden onset proptosis because of bleeding into the lesion. There will be a heterogeneous density, so it's either microcystic or macrocystic, which will show fluid levels. And these are no-flow lesions, so they will not take up contrast. The quickest way of dealing with it is draining it. And nowadays, we aspirate the lesion and inject bleomycin, which acts as a sclerosant. So to summarize, it's a no-flow lesion. It increases with upper respiratory tract infection. There may be a sudden increase in size, and we may drain it surgically or aspirate and use sclerosants. The next lesion are the distensible venous malformations, previously called venous varix. These are low-flow lesions, and they increase in dependent position or with Valsalva. Normally, they may be causing an enophthalmos. The patient may have pain on exercise. If there's a thrombosis, there may be sudden onset proptosis or pain. Non-distensible venous malformation includes the cavernous venous malformation, which used to be called the cavernous hemangioma. This is also a low-flow lesion, so it'll show contrast uptake in the venous phase, and there's a slow growth. It's a circumscribed lesion. It may cause compressive optic neuropathy or gaze-evoked amaurosis or acquired hypermetropia. It will take up contrast slowly, and the treatment is surgical excision. There may be a combined lesion, a combined veno-lymphatic malformation. So this will take up the characteristics of the dominant component. So it may be a low flow lesion or a no flow lesion. There may be an intracranial component. It may be diffuse or circumscribed. For instance, this patient has a veno-lymphatic malformation. The elongated appearance in contrast to the almost globular cavernous venous malformation differentiates it, as does the existence of the phlebolytes. And this is treated once again by aspiration and injection of sclerosant. This is an example of a patient with veno-lymphatic malformation. The first treatment was injection of cyanide-acrylate glue and debulking, and subsequently the patient underwent several bleomycin injections. And this is the current status. For the last 1 year, it's been stable. So to understand a veno-lymphatic malformation may need multiple sessions of treatment. The high flow lesions include arteriovenous malformation and fistula, which will cause a pulsatile proptosis, which may show vascular entities around the eye and engorged episcleral blood vessels. And there may be a buoy, or usually need interventional radiology units help. The AV malformations include pulsatile masses, which have feeder vessels from ophthalmic artery. We need to coil the feeder vessel and then excise the nidus within 48 hours. The arteriovenous fistula will show flow voids within the cavernous sinus, and it may show an enlarged superior ophthalmic vein. It can cause edema, chemosis, limitation of movement, and responds very well to coiling. Syndromic ISVA lesions include Faces syndrome, Sturge-Weber, Osler-Rendu-Weber, and Wyburn-Mason syndrome. So to take home, for appropriate management of vascular lesion, we need to know the history, the onset. We need to do a dynamic evaluation where we look at the pulsatility and the distensibility. We select the imaging modality, contrast enhancement, and which phase, interpret the imaging, and then select the management strategy. So there's varied treatment for varied lesions. Thank you.
Lakshmi, can I ask you a question?
Sure.
An excellent presentation. You have highlighted the ISFA classification so well. I just want to know, what is your preferred management of orbital varix?
To be honest, I have never yet intervened in an orbital varix because most of them are, it's asymptomatic. And the risk-benefit ratio becomes, rather daunting. I have seen one patient with a thrombosis in an orbital varix, and the interventional radiologist helped to clear out the thrombosis, and they first coiled, but that's the only experience I have of it.
These are real challenging situation. Even I agree. So in my hand, if I see that it is little superficial, then what I try to really expose it very well, ligate the main vessel that I see, then I put a cyanoacrylate glue. And then I try to excise. But when I do the excision, not with a normal knife or anything, but with the electrocautery. I have done at least 2 cases like this. But if it is deep, then definitely sclerotherapy. I think that is what I prefer. Even if you give bleomycin, it
Thank you.
quite a much, like it decreases in size.
Thank you, Kasturi. We will now move on to the next speaker. Shambhavi, will you start sharing?
Yes, doctor.
We have Dr. Mokpia
everyone.
Goswami
At
speaking
the
to
outset,
us.
I would like to thank the KOS Scientific Committee for the opportunity. I will be speaking on injectables in aesthetic practice. I have no financial disclosures. I am often asked why aesthetics in eye hospital. I believe that as an oculoplastic surgeon, we have great insights and nuances into the nuances of periocular anatomy, which gives us an edge over dermatologists and plastic surgeons. We have better hand control because we routinely give periocular blocks and intraocular nerve block, and all the aging changes occur around the midface. And we being ophthalmologists, we are confident to work around the eyes. Talking about facial aging, we know that there is loss of collagen and elastin as we age, and there is loss and redistribution of facial fat. We have two fat compartments, the superficial and the deep, and loss of support of facial soft tissues, and the resorption of bone when we age further. When we compare the aging changes in a 45-year-old daughter and a 70-year-old mother, we see that there has occurred receding of the hairline. There are deep horizontal furrows. There is drooping of the lateral part of the eyebrow, which is called Ptosis, and there's dermatochalasis. There's hollowing of the superior sulcus, loss of subbrow fat in the mother. There is bags. There is deflation of the cheek and descent of the cheek, which has caused the nasolabial folds to deepen, and the lips have become thin, and there's formation of marionette lines, and a heart-shaped face has got converted into a square-shaped face. If I compare the aging changes which happen between a 24-year-old and 44-year-old, I put up my photo, and you can see that there is eye bags, and there is formation of nasolabial fold, which was almost not there, and there is marionette lines, and the sharp definition of jawline has gone away. We need to understand the difference between dynamic and static wrinkles. Dynamic wrinkles are those which are formed due to facial animation while laughing and smiling and talking, and which are not there at rest, as you can see in this lady. So what can be done about all these? In addition to dermaceuticals, which are skin creams and the skin resurfacing tools, we have injectables, which is the focus of our topic today. What is botulinum toxin? Botulinum toxin is an FDA-approved prescription injectable. It temporarily decreases muscle activity and thereby softens and eliminates dynamic wrinkles. It prevents the formation of static wrinkles. Results are seen in about 3 to 4 days. Full results are seen in 2 weeks, and it eliminates only the dynamic wrinkles and does not eliminate the deep wrinkles. There are various types of botulinum toxin A available. The onabotulinum toxin, which is Botox, the infobotulinum toxin, which is Geomin, the prabotulinum toxin, which is Genio, and the Nabota. And we also have abobotulinum toxin, which is Disport. They share the same active neurotoxin, different purification process, presence or absence of accessory protein, and different therapeutic response and longevity. What are fillers? Fillers are injectable substances which add volume under the skin. It is usually commonly hyaluronic acid gel, and the common regions where it is injected are tear trough, nasolabial fold, smile lines, cheek, lips, and jawline. And results are immediate, and they last for about 6 months to 2 years. And bruising can happen and can be covered with makeup. The hyaluronic acid gel, which are commonly found in Indian market, are the Juvederm range from Allergan Cosmetic, the Restylane range from Galderma, and the Boletro from Merz. There are skin hydrating hyaluronic acid gel available, which are of low viscosity, and they are used for hydrating the skin, for rejuvenation of the skin, and for fine lines and wrinkles. That is Skin Booster from Restylane, Polite from Juvederm, and Profilo. They have their own protocol of injection, the injection sites, as well as the how often to repeat. Restylane Skin Booster and Bolite can be injected in the under eye area to prevent fine lines and wrinkles, and in the treatment of dark circles. This young lady has deep furrows in the forehead, and whenever she talks or laughs, these lines appear, which are quite unaesthetic. And botulinum toxin injection, this happens because of the overaction of the corrugator process muscle, and botulinum toxin injection can fade away these lines. And you can see this was how it was before, and this is after 1 week of injection. The forehead looks much more relaxed. This is again one before and after of botulinum toxin injection. The forehead lines The horizontal lines on the forehead can be eliminated by injection of botulinum toxin into the frontalis muscle at multiple points. This is before and after of injection. And this is one other lady. Here you can see there's so much of bunny lines, lines which appear on the nose, and here it is absent. Also the crow feet on the lateral canthus has gone away, and the forehead lines have also gone away after botulinum toxin injection. This is again before and after of crow feet. In both the pictures, she is smiling. However, the fine lines have gone away. The second picture. This is how injection is done for crow feet. The needle is pointed outwards. Subdermal injection at multiple points are done, and a bleb is raised. About 4 units at each point is given. Miso Botox is one other indication where droplets of toxin are injected into the dermis at regular intervals, say 1 centimeter apart, all over the face to give glow to the skin. It can also be injected under eye lines and smoker's lines. Here is a photo of Miso Botox, where you can see that the forehead has brightened significantly. The complications which can occur during treatment in the periorbital area are dry eye, ptosis, ectropion, and quizzical and Mr. Spoke's brow. Tear trough deformity is something which is very common and commonly seen in people in their 30s. And there is loss of subcutaneous fat and thinning of overlying skin combined with descent of the cheek, which confers a hollowness and which gives the appearance of a dark circle. And hyaluronic acid filler is very useful in this. And here you can see before and after of hyaluronic acid filler injection, the tear trough, and with very nice results. And here you see that the deep hollow has gone away. And this is a photo taken where the hollow has absolutely gone away. A biplanar approach for tear trough filler is what is followed. First, the eyelid is supported at the zygomatic arch, and then injection is done directly in the tear trough area. After this, linear threading can be done in the subdermal plane in the lateral 1/3 of the tear trough. Hyaluronic acid filler can also be used for contouring the jawline. Here, 25 kg cannula is being used for the jawline. It can be used for chin shaping to make the chin pointed, which is very aesthetic. After having supported the face at the zygomatic arch, we can fill the nasolabial fold in a linear retrograde technique in the subdermal plane. We can also fill the hollow temples, which gives a nice convexity to the temples. Complications of filler can be arterial occlusion, which can either happen due to inadvertent injection into the vessel, or it can happen due to compression. High dose pulse hyaluronidase given in the golden hour is known to be helpful. And thus, my injection table always consists of hyaluronidase, which is commonly available in our operation theatre, and also some basic emergency drugs. Platelet-rich plasma is one other injectable. It is the human blood which is withdrawn, and the platelets are centrifuged, and the blood is centrifuged to separate the serum, and the serum contains a lot of micronutrients and growth factors, and thus it is considered to be very useful for fine lines, wrinkles, hair growth, and it can be injected in the entire face, which is called vampire facial, and also it can be injected just below the under eye for dark circles. One other injectable is a deoxycholic acid, which is injected in pockets of fat. Most common pocket of fat is the submental area, and this causes fat lipolysis. Thank you for patient hearing.
Thank you, Dr. Mopia. We'll take the questions later. I would now welcome Dr. Lakshmi Mahesh to be speaking about complex ptosis surgeries. Dr. Lakshmi is a very senior occuplasty surgeon, a former president of the Occuplasty Association of India. Welcome, Dr. Lakshmi.
Thank you, Roshmi. Am I audible?
Yes, clear.
Thank you very much, Roshmi, for this nice session. And all the previous speakers have done a wonderful job I think there's so much to learn all the time. Actually, I was thinking complex ptosis surgery. Right now, in the last few years, every case of mine is of ptosis is becoming some complex situation, is a complex situation. We all know that congenital ptosis, we like to overcorrect, but sometimes this overcorrection can become a problem because the parents have to meticulously lubricate and take care. There can be corneal issues because most of the time we land up with some undercorrection later. So overcorrection is definitely a complex situation where we have to meticulously guide the patients to take care of the child. Even though we get a perfect result, sometime down the line, it starts drooping a little bit. So this again is a challenge for us because, the parents come back and say, look, it was looking nice earlier. But the basic thing we have to educate them first itself is we'll basically look into the amblyopia factor, make sure the child doesn't lose the vision. And of course, lid lag and lag of thymus universally, we have to tell each and every case. I think they cannot be counselors like how we have IOL counselors. In occuplasty, fortunately or unfortunately, we have to spend time, and most of the time we have to do only the counseling. Undercorrect, this child I operated thrice. A grandchild of a doctor. I don't know whether they have come and seen any of you all in Bangalore. The last photo shows some amount of hypertropia because he was looking up. So it was first I did a sling before he was 1 because there was severe ptosis. Then I did a resection. That was not enough. This is where it is. And then again I did a sling. So I don't know whether he has undergone a 4th surgery because he's lost for follow-up. But this is how the situation is. And there's so much of pressure also. So sometimes you need multiple surgeries for that look and to make sure the child is not going in for amblyopia. This child I did about 20 years back, and about 8 years back, she came back when she was about 14, 15. And she had a very good correction. But then she went in, she had some renal problems and was found to have polycystic kidney. So we just don't know. We just think of ptosis and amblyopia, but there are so many other problems as well. So of course, as we all know about all the neurological problems, and very many a time, we hardly can do anything before those issues are sorted out. And we have a good pediatric neurologist to opine on these patients. At the most, we can only do a minimal correction because the bells may also be many times weak. And then of course, sometimes we have to resort to crutch classes. So I think decision making is the most important thing. Many years back, I used to watch Dr. Richard Collins talk, and that is what he used to say. I think determination of the cause, look at why it happened, go and it's the detailed history. And of course, review old photographs. And one cannot emphasize the importance of a good clinical evaluation. Again and again and again, we teach, even if your fellows do it, please cross-check it once again, no harm. There's no ego issue here, because just like a PC rent is like a ego buster or a leveler for our ego in cataract surgery, not getting a good result or making a blunder or a mistake because of want of a proper clinical evaluation is a big ego buster for us. So I think we have to really, and we cannot afford to compromise. Every case you put yourself in that shoe, or your child, or your somebody close to you in that, and decide. Marcus Gunn, I really like to wait nowadays. Earlier I was doing this 2-stage surgery. I'm not doing it anymore. I'm teaching a form of exercise, and I'm just waiting amblyopia, and I operate only a limited resection a little later on when the child has learned to control the jaw winking to some extent. Blepharophymosis, that's again a very difficult condition to treat, but I think the best is when we do a good transnasal wiring with a double Z plasty. Of course, you can do your C plasty, YV plasty, whichever plasty you're happy with. But again, sustaining that result which you get on the table, say from 30 millimeters, if you're able to decrease it to 18 to 20 millimeters, keeping that intercanthal distance of 18 to 20 millimeters long term, not losing vision due to amblyopia, correcting the associated squint if required. I would still prefer a 2-stage, but I think Kasturi is here. She likes to do a 1-stage procedure. It depends on each one's choice, provided the patient is comfortable, the child is not amblyopic, and overall cosmesis to some extent is because we are dealing with phimosis. So we should realize that whatever we do, we won't get that perfect result in this particular condition. Myasthenia, all your factors may be negative to begin with. You may then think, okay, the patient is stable, but many years down the line, this is about a 20-year follow-up, they again come back. So then at that time, you have to say, I'm sorry, you please have only neurological treatment at this stage. Worst case scenarios, give crutch classes. Be careful of this aponeurotic cases. Sometimes they can be scars like this, which can add to the woe. So you can just a reattachment may not be enough here. You may have to do some amount of resection as well. And make sure, like just like a masquerade in tumors, make sure that you have done that myasthenia test to make sure that they're not having that. Myasthenia, it's better to wait. I've operated very few cases of myasthenia. Aponeurotic, if you ask me the challenge between all the 4 cases, 4 types of ptosis, the biggest challenge is aponeurotic. Some of those page 2, page 3 celebrities I have not brought in here, I'm sorry. But really to get that look, even if they get that perfect look in primary case, they'll say, look, doctor, from this case, it's looking here, my lid lag is there, it's looking funny. So many things to tease. It's like that perfect patient 6, and 6 of cataract you get. They'll still not be very happy. They will be going on complaining of something or the other. Some of the patients, I mean. Double elevator, we don't generally like to do. You need a good squint specialist to correct the elevation and give it to you to some extent. Maybe a minimal hypotropia you can expect. This was one such case. She wanted to go back to Pune and follow up. And she had a lot of corneal issues. I was constantly in touch. Nowadays, you can constantly be in touch on WhatsApp to make sure, because there will be some amount of exposure keratitis and corneal issues, because whatever you do, Bell's will not improve to the full extent in double elevator palsy. Squint correction, you may have to do in certain cases. You have to get that sorted out first before you touch the ptosis. Some people like to retain their contours, so you will have to satisfy them. You may think what you may think is a good result is not necessary. They would like to keep their contours. So a very good detailed discussion preoperatively is very essential. And as they grow older and older, the congenital ptosis, you should realize, and even the acquired to some extent due to certain causes like repeated inflammation, the levator goes in for severe fibrosis. Sometimes you land up even in this age doing a maximum supramaximal correction to get that good result. Because then again, that marriage issues like, oh, doctor, I want to look the best. Please do something. Now, thyroid issues, and we are facing a lot more after these 2 COVID issues in the last 2 years. We're going to see more and more thyroid with a little bit of prominence, little bit of ptosis. We don't know if they're going in for early thyroiditis. And the worst cases are those that who are euthyroid, because they will say, oh, my levels are normal, please operate me. But somewhere down the line, if you do their antibody test or if you do their T3 levels, then they may show some amount of thyroiditis. But again, the TSH level may be normal. So balancing all that and taking them up at the appropriate time is important. You must tell them that there will be a little bit of disparity. A little proptosis may remain. And this girl is almost a 13, 14-year-old follow-up. She's doing well and her thyroid levels are also good. This was another such case. So it's a complex situation. Actually, if you ask me, the complex situation of mechanical ptosis, traumatic ptosis is much easier to handle, because you can explain to them very well, this is what you can expect, and they're happy with whatever result you get. And these are the acquired ptosis, the congenital, as they grow a little old, these are the ones which are very difficult to satisfy. Just make sure you know your anatomy extremely well, detailed preoperative assessment, and look at all these blood thinners and all which they take in acquired ptosis much later. That is the involutional or senile ptosis. You would like to stop them a little earlier and be in touch with them on WhatsApp. You ask them for nocturnal lag, ophthalmos, corneal issues, lid thickening. And for last many years, I've been telling you, for even 0 millimeter function, I'm doing maximal or supramaximal resection. I am not doing a sling surgery anymore. I follow Dr. Betharia's words here where he says, hang a man last. Yes, I don't want to do it. Then pubertal corrections are, at puberty, they come back. So they will have residual lag of ophthalmos, but you still have to correct. Facial hypoplasia, you have to pick up. This was one such case. She was operated already twice elsewhere. She was sleeping with 10-15 cats in her room. She had severe allergic issues, so you have to tackle all that. They have psychological problems, divorce, lot of things now. They have played your now you did. So sometimes you wonder, like blepharoplasty, should we have a good psychological counseling? There's no point in sending them to a psychiatrist. They'll put them on medication and they become like zombies. You do the counseling yourself, take them into confidence, and try to get the best maximum result. Thank you very much.
Thank you, Dr. Lakshmi, for sharing your experience and wisdom with us. And since you've already spoken about blepharoplasty, we will now go on to Dr. Fairouz, a very dynamic oculoplastic surgeon who's also very active at the All India level, to be talking to us about blepharoplasty. Welcome, Dr. Fairouz.
Hi to all, greetings, and thank you Karnataka State Ophthalmic Society, Dr. Ellen and Dr. Roshmi, for this kind invitation, and congratulations on curating an excellent session. So I will be taking you through the topic of blepharoplasty, a brief overview in the next 8 minutes and few practical tips. I'm Fairouz from Bangalore. I have no financial disclosures or interests. As aesthetic surgeons, I'm sure we all believe that the most expressive part of your face is the periocular area. So blepharoplasty is basically the reshaping of the anatomical structures in the periocular area to give a youthful appearance. And all the more reasons in the recent past where that's the only area which is visible and more expressive when you're masked all the time. So most of the time we have seen that aging is very pronounced. The changes when you age is more pronounced in the periocular area. The beautiful Sharmila Tagore, she has aged gracefully, but also that most of the changes has happened in the periocular area. Cosmetic surgeries sometimes might go beautifully right and sometimes it can go wrong. So there are few indications in the rejuvenation of the periocular area, including the surgical correction with blepharoplasty. It could be aesthetic, purely aesthetic, or even functional in these patients where they have defective vision, periorbital discomfort, difficulty in elevation of the upper lids, and due to the heaviness, they might have even a tension type of headache. Although blepharoplasty has been introduced in the 18th century by von Graffe, there has been tremendous change in various surgical techniques in the recent past, and also inclusion of conservative, addition of conservative approach along with blepharoplasty to give it more rejuvenation. So the different types are upper lid blepharoplasty, lower lid blepharoplasty, and quad blepharoplasty, which includes all the 4 eyelids bilaterally. I just want to highlight this particular publication from the American Society of Ophthalmic Plastic and Reconstructive Surgery, where they have polled the members. And even in the United States of America, it has been found that 70% of the cases are functional and only 30% is purely aesthetic. And it's very, very true in my practice as well. So going on to, it's very important to do a pre-operative counseling and evaluation, a very meticulous evaluation. So the first thing that I do is to compare the patient's pictures, how he looked earlier, sit with him, and then also identifying their expectation and also be very honest with the results that they can achieve with the surgery. And the meticulous clinical evaluation is very, very important to identify other causes of, blepharoptosis, dermatocalasis, and even lower lid bags. So we do take certain measurements, which is very important, even in millimeters. When we do blepharoplasty, the markings are done so that you don't land up in adverse situations. So in my practice, one major principle that I follow is a conservative approach where doing less is more. It's always easy to go and modify things rather than excise more and then land up in a bad situation. So a few case scenarios here. This patient came with a complaint of he's not liking the bulge in his right eye, where he also has this yellowish spot in his right eye. So, well, what we did was a blepharoplasty bilaterally with symmetrizing the lid crease, and this is how he looks like, where both the complaints has been taken care. So this lady came in with the complaints that his eyes are not same anymore after a ptosis surgery that she underwent in the left eye. She has multiple lid crease over here. She was concerned. These patients are very precise. And what we did was to go ahead with blepharoplasty, both eyes, with symmetrization of the pretarsal show. Patient who has undergone an excellent cataract surgery with 6x6 vision, still not happy with the vision. And what he has is blepharoptosis, both eyes, which is more in the left eye, and of course, an excess skin with dermatochalasis in both eyes. And what we went ahead doing was a bilateral levator palpebrae superioris resection with blepharoplasty in both the eyes, and he was extremely happy post-surgery with the vision as well as the youthful appearance that he has achieved. And this is a professor who came in with complaints of compromise in vision, and especially his field of vision, and he has lot of excess skin over here, some amount of brow ptosis and lash ptosis, and this is what he underwent, where I had to do an additional bropexy along with blepharoplasty in this patient. This is a recent patient that I have seen, an excellent, very intelligent professional who came in telling that he feels as if a curtain is falling down in front of his eyes, and especially when he's driving at night. And this was referred as a case of a ptosis, but actually it's not ptosis. It's a lot of excess skin, that is dermatochalasis, which is causing a lot of visual obscuration. As you can see here, even his field of vision is compromised because of this excess skin. And this is the amount of skin that has to be excised, and he is scheduled for upper lid blepharoplasty in the coming week. This patient came in, a young patient with the complaints of I look tired. And as you can see here, she has a lower lid bulge. And so the lower lid bag, there can be various reasons. It could be a cheek descent, a hollow tear trough, pseudo herniation, including that, skin laxity and sun damage. Orbicularis hypertrophy has to be evaluated, where it can be treated in a different way, triangular cheek festoon, and also rule out eyelid fluid. Now, so for her, as you know that there is a lot of fat loss in the periocular area and the face as the age progresses. So there has been a lot of discussion on fat draping, which is additional to fat in the lower lid blepharoplasty. And she underwent exactly a lower lid blepharoplasty with fat draping. And this was how she looks after 1 week. And this is after many years of lower lid blepharoplasty. So I feel very fortunate when your own people trust in your work. And this is my sister, who was very much concerned about a lower lid bag, and then she went ahead with lower lid blepharoplasty with fat draping, and this is how she looks before and after. So the principles and techniques are straightforward. We go transconjunctival with very careful dissection of the fat and conservative excision of the fat and fat draping if required. Very important to identify the structures, especially the superior oblique tendon, trochlea, and lacrimal gland superiorly, and the inferior oblique inferiorly. This patient came with puffy eyes, and he has undergone a ptosis surgery elsewhere for the left eye. And the only request he had was, please don't make me look like as if I've undergone a cosmetic surgery, and make it very, very natural. So he underwent quad blepharoplasty with a SMAS lift for the facial rejuvenation. Sometimes in my practice in ocular oncology, blepharoplasty comes really handy with a large seborrheic keratosis in the left eye, where I had to have a skin graft, which was taken from the contralateral eye after a blepharoplasty. And this was like how the patient looks like. Xanthogranuloma bilateral. So what she underwent was debulking of the xanthogranuloma and blepharoplasty. So to conclude, identify the indication, functional and cosmetic, can walk in. We might have many patients after cataract surgery who has dermatochalasis affecting the vision, which has to be dealt with, which might go missed in your routine clinical practice, and it will be very, very helpful for these patients. Meticulous and preoperative evaluation after explicit counseling. You take up the case, and always in my practice, I aim for near natural appearance, and of course, aiming as much as for precision and symmetry. Thank you very much for your patient listening. And I also believe that nothing can dim the light that shines from within, whatever your face looks like. Thank you so much.
Thank you, Dr. Fairuz. we will go on to the next speaker, Dr. Ajay Krishnamurthy. He will be talking to us about use of endoscopes by oculoplastic surgeons. He is himself an oculoplastic surgeon who's skilled in the use of endoscopes, and he will give the pointers so that many of us who want to convert will be able to convert. Thank you.
Can I request Ms. Shambhavi to kindly start my presentation?
Yes, doctor.
Thank you for the kind introduction, Dr. Roshni.
Dr. Sher.
Extent can it be beneficial for my mentors and colleagues? Good evening, distinguished chairpersons, my mentors and colleagues. I'm Dr. Ajay Krishnamurthy, consultant at Narayana Nethralaya, Bangalore. I thank Karnataka Ophthalmic Society for this opportunity. Today, I'd like to talk about the use of endoscopy in oculoplasty. Why do we need endoscope in oculoplasty when the structures are so easily accessible and also the conventional procedures are working so well? To what extent can it be beneficial for us? Let's see. For example, in the orbit, when we consider, here you can see a picture of a lady with thyroid eye disease, with right eye proptosis and optic neuropathy because of the compressive disease. She underwent a medial wall decompression. Post-operatively, her vision had improved and her proptosis had also reduced. Another patient where there was a biopsy-proven squamous cell carcinoma involving the medial orbit and the nasolacrimal duct. He needed a combined orbital and an endoscopic approach for removal of the tumor in toto. When it comes to cosmetic, endoscopic upper face and eyebrow lift is considered, and also the mid face lift can be performed through the transconjunctival to lower lid approach. Even for harvesting the fascia lata for ptosis cases, endoscope can be employed, where it requires only a small incision for harvesting the fascia lata. So might ask, Crawford's stripper also requires a smaller incision for harvesting fascia lata, but has a disadvantage of unreliable graft length and the thickness. Hence, endoscope gives a direct visualization of the fascia that is being harvested. Coming to the lacrimal drainage system, where endoscope is extensively used, the disorders in question being primary acquired nasolacrimal duct obstruction and congenital nasolacrimal duct obstruction. There are a lot of studies which debate which kind of procedure is better, whether it's external or endoscopic. Though it has been hardwired in us saying that external DCR is the gold standard, always has better success rates compared to the endoscopic DCR. But both have their own merits and demerits. When the patient selection is accurate, external and endoscopic DCR have equal success rates. So why do we endorse endo-DCR above external? It can be because of avoidance of a cutaneous incision, less disruption of the medial canthal anatomy and the lacrimal pump, decreased operative time, intraoperative hemorrhage, postoperative morbidity, and also the ability to concurrently address sinus or nasal pathologies during the surgery. One main thing is endo-DCR can be done at the time of acute dacryocystitis, whereas an external DCR is not possible. So how do we do endo-DCR? As I had previously discussed, patient selection is important. We have to identify the pathologies like DNS, atrophic rhinitis, acute infections, nasal polyps, and malignancies first in the OPD, treat any acute infection or allergic rhinitis prior to the surgery. The equipments which would be required for endoscopic DCR would be an endoscopic unit with a camera, light source, endoscopic instruments, along with the telescopes. So I'd like to show a video of the endoscopic DCR. Here is the picture showing the lateral wall of the nasal cavity, showing the septum, middle turbinate, inferior turbinate, maxillary line, and the axilla of the middle turbinate. So it has been already decongested with lidocaine 4% spray and lidocaine 2% plus adrenaline injection. This diagram shows the probable landmark of the lacrimal sac situation in the lateral nasal wall. The incision site would be superiorly 8 millimeters above the axilla of the middle turbinate inferiorly halfway through the middle turbinate, anteriorly just adequate for the nasal flap to be elevated. So after the incision is done, the mucosal flap is raised from the frontal process of the maxilla towards its edge, and the flap is excised. The bony ostium creation is started with the Kerrison ronger, which is alternated with a high-speed drill so as to remove the bone where the thickness is very large. The bony ostium is extended till the lacrimal sac is completely exposed. Once the lacrimal sac is exposed, a crescent blade or a keratome is used to cut along the length of the lacrimal sac and the NLD, and side cuts are made so that the lacrimal sac flap falls on the nasal mucosa. Bicanalicular intubation is done, and the bodkins are exteriorized from the nasal cavity. As we can see here, once they are exteriorized, the area is dried, fibrin glue is applied to the lacrimal sac and the nasal mucosa junction. The flaps are opposed to each other with the help of fibrin glue. The stunt, which is cut, tied, and engaged to the middle turbinate. The collection of the blood and the fluids is aspirated from the posterior nasal cavity. Nasal packing is done along the floor of the nasal cavity, so avoiding disturbance at the operated sites. The most common complication that we can have during the nasal DCR is the failure of the procedure per se, others being progressive cicatricial closure, development of adhesions, formation of synechiae, granuloma formation, or persistence of a lacrimal sac diverticulum that was not drained during the surgical procedure. Here, I'd like to show you a case of failed DCR, which was caused due to the granuloma formation and extensive scarring at the ostium. The granuloma and the scar were excised, and the rest of the procedure were similar to what we had seen in the previous video. Whereas congenital nasolacrimal duct obstruction can be because of two types. One is a simple obstruction, that is because of the membranous obstruction at the valve of Hasner. The other being complicated obstruction, where there are different types. It could be a buried probe, a bony obstruction, non-development of the nasolacrimal duct, and NLD opening into the inferior turbinate. I'd like to discuss one condition, which is NLD extending up to the floor, which is lying lateral to the nasal mucosa, or also called as a buried probe. In this case, the lacrimal probe that is passed into the lacrimal sac and the NLD lies along the wall of the inferior meatus, which is not visualized. So in such cases, when we do the syringing, it may turn out to be normal or patent, but there won't be an extravasation of fluid into the nasal cavity. In such cases, endoscope is definitely required to make sure that the opening is made into the nasal cavity and not under the mucosa. So to conclude, endoscope is not only for convenience, but a move towards the future for more predictable and reliable procedures. Thank you.
Thank you, Dr. Ajay, for this great introduction to endoscopy for oculoplastic surgeons. We have a few minutes left, and for the audience, we have, all the speakers here, Dr. Kasturi, Dr. Lakshmi Mahesh, Dr. Mopia, Dr. Fairuz, Dr. Ajay. Any questions are welcome. So if there are no questions, we'd thank all the speakers for sharing their valuable expertise with us. It has been a wonderful session. Thank you to all the speakers, and you've been so good and so knowledgeable. And the chairpersons of the next session are already here, and I will hand over the session to them, Dr. Lakshmi Mahesh and Dr. Shivyogi Kusagar. Thanks.
Roshmi, hi. I have a question for Ajay. Can I ask?
Yes.
Ajay,
of course,
good
we have
talk.
time.
I'm meeting you virtually for the first time, though not in person. Now, you said you can use the endoscope transconjunctivally. How is that?
Transconjunctivally through the inferior phonacial incision. They have been using it for the mid facelift. I've definitely personally not used it. There are articles which describe their usage. So they go through the lower lid, transconjunctival, and then try to fix the cheek and the other areas.
It's nice that you're doing endoscopic DCR, but my sincere advice would be to just make a little bit bigger ostium. Bring it more anteriorly. But what you showed in the linear diagram, no, of the extent was perfect. But what you showed in the video, the dissection was not enough. What happens? You're using a powered instrument. You're using a drill. So scarring will be a lot. When you use your punch, chisel, mallet, and punch, scarring is less. But when you use powered instruments, the scarring is more. So the chances of whatever ostium you make becoming small. So evaluate your cases post-operatively, the size of the ostium at 1 month, 3 months, first 7 days, 1 month, 3 months, and come out with those results as well. It will be very helpful. Good, congratulations. And Kasturi, what can I say? You're innovative all the time. So wonderful talk, and Mopia, you too, you're doing very well. All the talks were great. Roshmi, your talk was also good. Every single talk was very nice. Oh, of course, Fairuz, congrats on your new clinic. All the best.
Thank you, ma'am. Thank you so much. Thanks, Roshmi. Once again, it was great learning and seeing so many new things. Thank you.
Thank you all, and
bye.
Bye.
Thank you, everyone.
And Dr. Lakshmi will take over the session.